Greetings. This is Pat Schou, and I'm the Executive Director of the Illinois Critical Access Hospital Network. And I'm presenting this video today with Gregg Davis, who's sitting to my left, and we're going to discuss what a Medicare Shared Savings Program is and the role of the physician in this whole process. And I really appreciate him being here with me today to further explain to the physicians what that means to their practice and what it means to the rural hospital itself. The Critical Access Hospital Network began this journey several months ago, looking at whether it would be an advantage to be a community care organization and perhaps participate in a Medicare accountable care organization. We did some investigation and found that it was really a great opportunity, leveraging a number of hospitals and physicians together to look at coordinating primary care for the benefit of patients and moving to the new payment systems that we believe will be rolled out through additional healthcare reform. It was a great opportunity for us to look at different ways of negotiating with commercial carriers or looking at the Medicare Shared Savings Program, which we have done. A couple of weeks ago, this group of 25 critical access hospitals agreed to move ahead with a Medicare Shared Savings Program. And we believe this is a great opportunity to learn case management and move closer to value-based purchasing and really participate now while a Medicare Shared Savings Program through the federal government will allow you a shared savings instead of risk-bearing. Now you're probably wondering, if you're not familiar with what an ACO, a Medicare Shared Savings Program, it's a group of health care providers such as physicians and hospitals that work together to manage and coordinate a group of patients across the entire spectrum of the care for patients and accept the responsibility for quality and, of course, the cost in future programs. But right now, the first program that we think of this Medicare Shared Savings Program is the shared savings part, which we believe that we can endeavor and move ahead with. The application for this program is the end of this month, and I know it's really of interest for many of our hospitals and our physicians to understand and participate in this process. And that's why I've asked Dr. Gregg Davis, who is a practicing physician, an independent practicing physician in Princeton, to join me today and talk a bit about the role of physician in accountable care organizations and what he believes would be the future for that and why he would be interested in participating in such a program. So, Dr. Davis, if you'd be willing to share, a little bit about your background.
Sure.
And your experiences and what you think about ACOs and shared savings programs in the near future.
Well, my background is I'm a board-certified family physician. I've been in practice for 34 years. In Princeton, I was in a group practice for 20 years. Then I spent a little time as an interim CEO of a hospital, and then I've been practicing as an independent physician, a solo practitioner actually, for the last 14 years. During the same time, I've been on the board of directors at the hospital, and during that same time, I also acquired my MBA. So I've had a fair amount of experience, at least in the governance aspect of healthcare. And Pat approached me regarding ACOs and what physicians would
See whether it's a good thing or not.
Yeah, a good thing or bad, and basically how to implement something like this.
Particularly because you know both sides. You've looked at the governance, the management of practice, as well as being in practice itself with patient care.
Yes, I'm in your shoes. On a day-to-day basis, I deal with how do you make ends meet and pay your bills in a practice, and what are the stresses that are going to be placed upon us, along with the advantages that are going to be coming down the road with managed care.
Very good. Well, as I said at the beginning of this video, is that a group of critical access hospitals and other rural hospitals in Illinois have agreed to move ahead and explore this Medicare Shared Savings Program, submit an application at the end of this month, and begin this whole process of developing it. And very important to have the role of the physician in there because you'll be equal partners in this whole process. And so to further explain the role of physicians, I'm going to ask Dr. Davis a few questions, and we hope we can tease out the information that will be helpful to you as a physician, considering this as an option for you. So why do you believe a Medicare Shared Savings Program would be a good opportunity for a physician either employed by the hospital or in independent practice like yourself?
I think first of all, we're all seeing hospitals around us. I know particularly around me, I've seen 2 hospitals being acquired by the large systems, and therefore basically losing their own ability to determine their own destiny. And as physicians link with hospitals, and as hospitals link with larger institutions, we as individual practitioners and our independent hospitals continue to lose our independence and our ability to determine our own destiny. This is an opportunity to become involved at the ground level of an ACO and help shape how that develops. And as that develops, really not have it so much be told what you have to do, but having an opportunity to actually determine what you're going to have to do.
Especially if you're not ready to participate in a large system or it's not an option for you. This gives you a chance to really collaborate with fellow physicians and hospitals that are providing care in rural communities. You can be part of that collaborative process.
Yes, and in addition, there's a lot of things that we're going to have to, systems that we're going to have to develop. And if we're involved in a system like this, you don't have to reinvent the wheel every time. You can use somebody else's wheel and maybe just tweak it a little bit. And we've all got enough time invested in taking care of patients that there's very little time left in our lives to become involved in the infrastructure of managed care and the reproduction of systems in order to make that work. This is a way that you can save significant amounts of time, hopefully being able to actually create additional revenue streams in the future and not have to reinvent the wheel over and over again.
New revenue streams based on prevention and some other kinds of areas that we are striving to do under population health management.
It's, we've all heard about value. The concept being how much does it cost and what do you get for it?
That's right.
Well, we hopefully can increase value and actually acquire some additional revenue streams while we're controlling what's happening and maintaining our own independence. And that's really the key of what we can do.
And focusing on primary care as the base in our specialty and other services, mental health and other things built around it.
Yes.
Very good. What do you think the MSSP would provide as a value for a practicing physician? We probably went through it in our discussion just a minute ago, but what do you think it provides our patients, or you're thinking it would provide your patients?
I think what it is going to provide your patients is an opportunity to continue receiving care the way they are now. Meaning that you will be able to be involved as a physician in the determinant of how care is delivered to your patients. And your hospital will be able to be involved in determining how that care is played out in your community. It'll happen locally. It'll happen in collaboration with multiple other people just like you, instead of you being told what's going to happen next.
Very good. What about the requirements for quality reporting? And that's always on everybody's list there. Oh, reporting more data. And I know you have been very active in reporting your physician quality data this past year. And I know with the Medicare Shared Savings Program and with any type of a managed care program, we're going to have to look at showing our value and reporting quality. So if you talk a little bit about your experience.
My experience has been with PQRS. We've been utilizing PQRS now for about a year and a half, and we reported for the first time last year on the first, 4 or 6 quality indicators. We're now tracking 18 quality indicators monthly, and we found it quite helpful. Actually, somebody brought up to me that everybody thinks they do a good job in controlling their blood pressure, their patients' blood pressures, until you sit down and look at the aggregate data. And then you realize that, maybe I should have been a little bit more aggressive here and there. And we see that, in lots of things. Our patients are now, we're getting the PSAs. I know I'm getting the PSAs on timely. I know my women are getting mammograms as they're supposed to do. I know my lipids are being monitored at the right frequency because I have systems in place that tell me to a patient at real time when I'm actually seeing the patient that I need to get a lipid profile, I need to get a PSA. She hasn't had a mammogram in the last 10 years or whatever. Bring it up, and we can work it into the system, the flow of patient care, instead of sitting down with reports and trying to create letters, and
Sure.
that just, nobody has time to do that. So,
And that's very important, is to have good use of your time.
yes.
And one advantage with the Medicare Shared Savings Program, why the group has chosen to move ahead with that, is that it uses the physician reporting system now in place and
Mhm.
builds on that. Those that have rural health clinics, there'll be a few in there that they will have to report. But there's not new measures other than those we might look at as this program evolves to improve patient care and improve our services. So,
Once you set up the systems to capture the data, and that's what we can help you with as an
Right.
organization, setting up the systems to capture the data. That is the hardest part of the whole process. But once you've got those systems in play, it really is very simple after that.
and we've talked a little bit about care management and transitional care and the role of this in patient practice, with a physician, with a accountable care organization. How do you see that evolve with your practice and moving towards value-based with care management, transitional care from one level to the other?
Well, I can talk maybe a little bit about where we were a couple of years ago
That's great. That's
in
great.
my practice, and then how we've evolved and how we're still evolving. We're still early in the system. 2 years ago, we would send patients to a cardiologist, that was 60 miles away. I would frequently get a letter back at some point in time, maybe 2 or 3 months. I may or may not get a telephone call from the guy when he got done doing the heart cath. We've developed systems now that we track. Did the patient go to the consult? Did the consultant get information back to me? We close the loop in the information loops, and by closing the information loops, we really have a better understanding of where our patients are and when they weren't compliant with what we recommend them to do. Right down to the point of, if we sent you for a mammogram, and you decided you just were going to
Sure.
fail with compliance. It happens all the time. We all know it. We can help you develop systems in order to determine that non-compliance, both by your consultant and by your patient, and really improve the quality of the care that your patients get.
So you see participating in a group with your Medicare Shared Savings Program, this would be an opportunity as a group to monitor that and approve those transitions in care management. Do you see the value of that?
I think our transitions can be smoothed out, but I also think it has an opportunity ultimately, as we as an organization here are able to improve our data capture, we can look at outcomes of various specialists and provide you with, as a practitioner, provide you with the data you need to say Dr. X is doing the right number of heart caths. Dr. Y is maybe not doing enough. The next guy maybe is doing too many.
Sure.
And you'll be able to benchmark each of your specialists and really get a better idea about the quality of care that they're delivering, and you'll be able to benchmark your institutions that you refer to and make better decisions regarding where you want your patients cared for.
And then really not reinvent the wheel, as you talked about.
Right. We'll help you get that kind of information and data.
Very good.
That's what quality is all about. It's really all about information. And not so much that you're not doing a good job, it's just we have to get the information together to really know where we need to make small tweaks in order to improve it.
Very good. What have you done right now in your practice to prepare, knowing this is down the road, and maybe being part of this group, this Medicare Managed Share Program?
Probably the first thing I did was say yes.
I know. Oh no.
But prior to that, PQRS indicators were a huge leap in the process. But before that, we had to get to the place where we were really electronic record driven. So we had a method to capture the data, and we worked more and more, and we continue to work on improving the quality of the data that we're able to capture.
Very good. What do you think are the advantages, or you see the advantages for your participation as a physician, and hopefully participation from other physicians in this program?
I think I may have said it before, but I think this is the single most important thing that an organization like this, or that it can provide us, is with the ability to not reinvent the wheel as we put systems together. and the ability to maintain local control of our destinies, both as hospitals and physicians, in our ability to care for patients.
And participate perhaps at really relatively low risk in the fact that this is a shared savings program, not a risk-bearing,
Right.
and there's no immediate participation fees required and data required right up front that we'll build it as we go.
Well, and then really all we're asking of you, as a physician, is a signature that says that you will work with us as we develop this. We're not asking you to send us a check. We're not asking you to take on a risk of outcome of how you're going to manage your patients. We're not telling you how to manage your patients. We're just asking for a signature that says you will work with us over the period of the next 3 years as we develop this, and we're basically asking that you are committed to the concept.
Right, and you can.
And that's it.
And you can opt out.
Yeah.
It's easy enough with that. But we hope you continue because, as Dr. Davis points out, it's a chance to be part of the process to improve care programs and not have to reinvent the wheel and use resources that are available. Do you have any concerns about participating in an MSSP, a shared savings program that we've been talking about? Besides government control.
Right, yeah, right. My only concern is that, as we put time into this, as we as physicians put time into this, I want to make sure that I get value out. I want value both for my patients, I want value for my hospital, and I want personal value. And that, I guess that's my concern. And we're just going to have to work on it. I think as we all put more time, effort, and some little elbow grease in this thing, we can really assure ourselves that we, in fact, will get value out of this.
And make a difference for our rural communities at the same time. Well, in closing, I really appreciate you spending your time and sharing your views and ideas and advice and recommendations for fellow physicians out there. But in closing, anything you would like to add and give the pitch for?
The cost and the risk of getting into this is essentially nothing, as I see it. The upside is significant in your ability to maintain your own independence, maintain your ability to keep control local in your communities, your ability to provide hopefully even improved quality of care to your patients, and ultimately assist your community in continuing to control its own destiny in medical care.
Very good. Once again, thank you, Dr. Davis, for spending your time. I appreciate it very much.
Thanks,
and please, if anybody has any questions, Dr. Davis or myself would be happy to answer them. And thank you for viewing this video. Thanks.
Thank you.